So we had just an incredible human interest presentation here that just was so moving. And now we're going to switch to something that just I'm so excited about because I'm a data geek. And now we're going to talk about data and research and connecting data and policy. And we have two incredibly well-informed speakers for this topic. First is Joan, the executive director of the Mental Health and Addiction Advocacy Coalition, or MHAC. She's been in that position since February of 2003. The coalition is comprised of over 130 organizations around the state of Ohio, including behavioral health agencies that serve both adults and children, health and human service agencies, faith-based community, government and advocacy organizations, major medical institutions, and entities from the corporate arena. The coalition fosters education and awareness of mental health and addiction issues while advocating for policies and strategies that support effective, well-funded services, systems, and supports for those in need, resulting in a stronger Ohio communities. As executive director, Joan has advocated extensively at the local and state levels regarding behavioral health policy issues. Additionally, she provides administrative and strategic support for the membership of the coalition and the leadership of the coalition, working with consultants and local and statewide organizations and coalitions to achieve goals that the coalition has set. She has a long history of experience before that, serving as the Director of Advancement and Legal Affairs for Bridgeway Incorporated, the Cuyahoga County Mental Health Agency, as the Legal Director for the American Civil Liberties Union of Ohio, and prior to that, as a litigation associate in the Cleveland office of Arlen and Hatton. Also presenting today is Dr. Tracy Najera, who is the Executive Director of the Children's Defense Fund Ohio, a nonprofit child advocacy and civil rights organization that has worked relentlessly for more than 40 years in Ohio to ensure a level playing field for all children through its use of data, research, public policy, and advocacy. She's the work on behalf of Ohio's vulnerable children of health, education, equity, child welfare, nutrition, with the goal of ending child poverty in Ohio and in the United States. Tracy's experience spans research, program management and implementation, and public policy. She's worked for Ohio's Office of Budget and Management, Patel for Kids, and in national consulting with Education First. And I'm just so thrilled to have both of these individuals with us today. So I don't know who's starting. Yeah. Whoever's starting, I invite you to come on up.
Thank you so much. Good afternoon, everyone. And I just want to take a moment to thank Randy Leidy, Dr. Leidy. Thank you so much. Thank the Ohio University and Appalachian Children's Coalition, and for all of you being here. I also want to acknowledge a couple folks in the room. First off, Governor Taft. It's so good to see you again. So Children's Defense Fund, yes. Children's Defense Fund and the Appalachian Children's Coalition, we get the good fortune, the honor of sharing a couple board members, and I'm so happy that Governor Taft, and is continuing his commitment to children here in Ohio and across the country. And also Tracy, thank you. So Tracy was my my boss at one point, and I learned an awful lot from her, so thank you for having us. So today's presentation, it's around data's role in policymaking, getting from A to B. And at this point, I'm going to go ahead and talk a little bit about this partnership between Children's Defense Fund and the MAC, the Mental Health and Addiction Advocacy Coalition. So we came together, association. We came together, it's hard to believe, almost 2 years ago with this vision of creating reports that really drills down into information, to data around children's behavioral health. Because I think one of the things that we can agree on is that there's a lot of idea around children's behavioral health. Is it better if I take this off? Mm-hmm. Take it off. Okay. But one of the things that we know is in, I think, short supply is having good data and having it at the grain size or the granular level you know, where those entities that have authority about what can happen or what kind of services or allocation of resources can occur, you know, at the level where that can actually happen in a very deliberate and smart way. So we set out on this quest, and I call it a quest, and it took quite a while to get this information, or to get aspects of information we believe useful to make. And I'm very thankful for her partnership and the partnership of MAC. And actually, I'm going to hand it over now to Joan, who's going to talk a little bit about what we're doing here today.
Thanks, Tracy. I appreciate it. And thank all of you for coming today. I just whispered in Tracy Plowk's ear. She should be very proud of herself. And same with you, Dr. Leidy, as well. This is just and before I give you the summary of it, I want to thank Jade and Beth in particular for your courage in stepping up and sharing your stories. I've been doing this, as was noted, for quite a long time, and I can talk until I'm blue in the face. The two of you and what you shared are what makes a difference. I can tell you that. I've seen it day in and day out. So thank you. Thank you. And to all of the folks that were talking about the services you provide, that you do, all of you, you've got strapped, it's burned out, it's low-paid jobs, it's underappreciated, it's stigmatized, it's all of those things. And notwithstanding that fact, you all get up every morning, you go to these jobs, you do these things, and you make a difference in the lives of people like Jade and Beth. So thank you for all of the things that you all do. I really appreciate it. And then the one final thing I just wanted to mention is, after sitting here for hours this morning, listening to all of you, I heard one common theme. It was that we need to continue in our community so that kids and their parents and their families, when young Ohioans need those services, they can get those services when they need it, where they need, and what they need in each of our individual communities. And it was that drive, that issue, that brought CDF Ohio and the MAC together to say, okay, what role can we play in doing all of this? And so this way too text-heavy slide, but it was just too good to not include all of it. Let me tell you, and because it was a real light bulb for me. So talking about data and policy, Tracy mentioned it. It's so important to get good data so that you can take it to people like governors and others, right, to inform them. But when I read this from this gentleman who works for the World Bank, he's the Senior Director for Development Economics at the World Bank. It was a conversation amongst a lot of really smart people at like a national, international level. He reframed it differently, and I so valued it. What he said was basically, yeah, we do need to do that. We need data to inform policymakers. But let's think about this for a minute. In the private sector, private companies lean hard into their data. They generate that data. They look at that data. They make decisions based on that data. So why is the public system so different from the private system? And he raised this point. He said, perhaps it's not always in some people's best interest to gather and lean into data. And so what we should be thinking about when we gather data is informing policymakers, certainly, but also informing people like all of us, informing the Jades and the Beths of what the data shows. Because then Jade and Beth and all of us can say, well, wait a minute, why don't I have that service in my community? Why are my kids not getting those services? Why are my parents not getting those services? And then mobilizing those people to now talk to policymakers and show them why we need that data and inform them of the importance of it. So we are hopeful that our report that we're going to talk about today not only informs policymakers, but informs the general mass in Ohio so that we can all lean in the same direction and get the data that we need so that we can get the continuum of care that we need for all young Ohioans. So I'll leave it to you.
All right, cool. All right. So what you have on your tables is an executive summary of a 300-plus page report that was produced back in the spring, and it's called Mind the Gap, Creating a Robust, continuum of behavioral health care for young Ohioans. So a couple things that I want to share about this report is, first off, this is our attempt to provide a detailed and systematic look at overlapping systems of care and unmet needs that impact behavioral health for young Ohioans. And what I mean by that is, we'll get a little bit more into that, there are multiple systems that interface with young people that have an opportunity to either provide direct services, referrals, diagnoses around behavioral health that we want to recognize in this report. So lots of opportunities here that we want to seize upon. It proposes a continuum of care that identifies the types of behavioral health services that should be available to every child across the state of Ohio at every age and stage of development, from prenatal up to age 26, and along with their caregivers. And we'll get a little bit more into why we chose that framing. Also, the last thing is we provide individual county profiles that include results from a survey of Ohio's Adams boards on local availability of services that are available to young Ohioans and their families, as well as information, data that we were able to secure from the Department of Medicaid on behavioral health conditions and utilization of services. Now, we believe that the data from the Department of Medicaid is a good proxy, a good reflection of what's occurring across the state with young Ohioans. About 50% of our children actually are covered by Medicaid. And as you know, getting that private health insurance data is very hard to come by. And then we also have a swath of providers that, let's face it, are cash only. So we believe that this is a good proxy. It's a good, I think, estimate of where we are, county by county in terms of children. Now, what really drew us to this work is that there are a lot of implications that are wrapped up in this conversation around children's behavioral health, and things that not only affecting, the individual or the families, right, that are experiencing issues, but this impacts communities. This can impact our states in so many ways. So that young Ohioans access services, ongoing treatment of care for complex circumstances, positive life fit for all Ohio. About that for a minute. Able to do for children in terms of services, in terms of diagnoses, in terms of supports for not only them but for their families, it positively benefits them, yes, but all of us, all of our communities as well. So this is not just, an investment that we're making in an individual. This is an investment we make in a community and in our state. And when we talk about positive life outcomes, I think with that calculus, you also have to think about, avoided negative life outcomes too. Children who have heightened levels of behavioral health issues that are unaddressed, they suffer personally, not just in that moment in time, but for the rest of their lives, and the people around them as well. And I know we can do better than that. Comprehensive, more equitable policies are needed to resolve the gaps in behavioral health services that are available to young Ohioans. So what we're talking about here is that, we do have a system of care, right? Are there gaps? Are there, leaky pipes along the way? Are there areas where that's not as resourced? Yes. So we need something more comprehensive that's equitable. To Joan's point earlier, it shouldn't matter where you live in this state or where what your background is, the color of your skin, your zip code, and none of that should matter when you're trying to access care for yourself or your child. Ohio's workforce. Now, this is a big one, and I'm sure that this is something that all of you have seen at one point or another. Our workforce now or later will be impacted by the decisions we're making around resource allocation and the provision of services for young Ohioans around their behavioral health. And I'm sure you guys have heard this saying, and one of my former mentors would say this all the time. He'd say, you get hired on the hard skills, fired on the soft skills. And for a lot of people, soft skills, that's wrapped up in behavioral health. It's wrapped up in whether or not you're able to self-regulate or whether you're coming to work healthy, right, both physically and mentally. So these are some of the main implications we just wanted to outline for all of you. Now, in terms of behavioral health prevalence, now all of you work, I'm sure, very closely with a lot of this data. So I struggle here in that I don't think I'm sharing with you anything new or surprising. But I'll have to be honest, I am not a behavioral health professional. I am more of a policy generalist when it comes to children. But some of these data points really gave me pause. When you think about, especially as a parent of 2 teenagers, okay, when you think about 50% of all lifetime cases of mental by 14, this provides an recognize behavioral health or mental health issues at that early age. Well, that means that we should be able to intervene early, right? Nationally, a higher percentage of children and adolescents 12 to 17 years old had a drug use disorder in the past year. All right, so this is also somewhat startling in that they had a higher percentage than adults over 26. Nationally estimated half to 3/4 of youth encountering the juvenile justice system meet criteria for mental health disorder, and 40 to 80% of incarcerated juveniles have at least one diagnosable mental health disorder. So in terms of this particular statistic, this is, number one, an opportunity for our behavioral health system to interact with youth in a positive way to figure out what kind of interventions are needed, but then also thinking about what could we be doing better and earlier. Down some of the issues that these children face in terms of their behavioral health, or let's face it, maybe not their basic needs being met. So in the state of Ohio, about 500,000 children and youth, young adults have a mental illness or substance use disorder. So when you think about that, that's like 1 in 5. So pretty high statistic here. Rates of teen suicide have spiked 46% over the last 4 years. And I just want to make reference to a report that our friends here at Ohio University did not too long ago, I believe the MAC, around suicide. And we are, and I'm going to borrow some of the terminology, the diseases of despair, right, are ravaging some of our communities. And I mean, it's one of those things, you see it happening, you recognize it's happening. Now, there's so much that I know we're doing about it and we're wrapping our arms around it. But at the same time, we know that there's much more we can do. More than half of children who experienced major depression did not receive mental health services, and only 1/3 received consistent treatment. So this one, I think, is really, really the pain point that a lot of us are seeing. Children who are experiencing this level of suffering and pain emotionally and not able to access services or consistent services. And let's face it, in this past year, especially during the pandemic, we know that a lot of children, especially in the region and other areas where we're more face-to-face, the options were limited, especially if a telehealth option were provided. If you lack broadband, if you lack a computer, the device, or the technology literacy to use it, you're not going to be able to get that consistent access to care in a situation where you're not able to go somewhere face-to-face. And also in a lot of our school districts, well, I guess in a handful of our school districts here in the region, where there's actually a behavioral health provider that's providing at the school for students, right? When those schools were closed, the child didn't have access to those services were disrupted. Now, in terms of our overlapping systems, so we believe that a robust continuum of care has many different entry points, whether they be for diagnoses, referrals, access to care. And it includes everything from your child care centers, like your Head Start centers, early care and education, to our schools, which is, I think, a huge player in this space. When a child is going in for, annual wellness visits, to also maybe, our courts or caseworkers and child welfare system. These are all opportunities for youth and families to have an interaction with a professional who could either make a referral or, on the spot say, you know what, there's something going on here, let's dig a little bit deeper. We believe also that this well-functioning system should have appropriate interventions at each of these points, depending on that need that might exist for the child or the family. So we've mentioned a couple of them here, and I think some of them that are, really exciting and interesting to think about are, those points of entry where you have the greatest percentage or the greatest number of children that are having interactions, and that would be our schools. Number and also our education as a the other ones, in terms of child welfare and juvenile justice, we know that a lot of them do have some type of protocols or even whether it be interview protocols or behavioral health checks, where they're trying to walk through what potential issues a child or a family might be experiencing, but we're suggesting that we need to double down on these and we need to strengthen them. Now, in terms of public health and racial equity impacts of 2020, as we were writing this report, we began before the pandemic. And as we were moving through this, as we were all moving through this, we were also trying to be very cognizant of the fact that so many of our youth were experiencing things in their families, were experiencing things that would have significant or represent significant disruptions or stressors in their lives, whether it be economic insecurity, isolation, loss of jobs, depression, again, uninterrupted or inconsistent behavioral health services, and anything that might have been, let's say, maybe before the pandemic, whether it be or whatever the case might be, our family were experiencing, it was exacerbated this last month. And in some, we're still experiencing a lot of that. But we wanted to recognize this phase in time, right, that we're all going through. So as I mentioned, it compounded already rising negative trends. And then also, I think, simultaneously, we have faced, a national reckoning, national dialogue around racism. And, at Children's Defense Fund, we like to repeat this and say this, that, children, first of all, they don't live in a vacuum. They see what's going on in their world. They watch the news with their parents, or a lot of times maybe not. They see what's going on social media. They're watching, however much we try to shield them. Children are watching what's going on in the world, and they have questions. And stress, internalize, resolve it. So as we all witnessed, the deaths of Breonna Taylor, George Floyd, Walter Wallace, and others, we know that the coverage, that the dialogue, that the comments, that the kind of vitriol that we've seen is having a negative mental health impact on youth who are Black, Indigenous, and people of color. And during the last year and a half, thankfully, one of our great data partners in this country, the U.S. Census Bureau, has been publishing household pulse surveys, reporting on its experimental data file. We can go into that later. But reporting on how families and children are experiencing the pandemic, nutrition, whether or not people are missing rent payments. They're collecting all on a weekly basis of time. But what it does is it gives us to see almost in real-time snapshots of where general, the general experiences of families and children are in this country. Oh, one thing here on, I forgot to mention. So as we're writing this report, these census pulse reports are coming out. And one of the things that we saw was that about a fifth of people reporting on this were reporting, that they had felt down, depressed, or hopeless in the week prior. And we saw this data, kind of fluctuate, in some cases trend negatively. So of course that was, kind of the context at which we were writing this report. Another piece was beginning in April 2020, the proportion of children's mental health related emergency room visits among all pediatric ED visits increased and remained elevated through October 2020. Compared with 2019, proportion of mental health related visits for children and adolescents ages 5 to 11 and 12 to 17 years increased about 24%, 31% respectively. So at this time, I hand over to my colleague.
So I'm going to talk to you about the report itself and some of the contents that were in it. We explained what we were trying to do with the reports. We started with this, an introduction to the continuum of care. And as background for all of you that may not be familiar with this, the continuum of care was developed after Obamacare was adopted. And it was adopted by SAMHSA, so the Substance Abuse and Mental Health Services Administration, and they created the Good and Modern Mental Health and Addiction Service System. We call that now the continuum of care. So what it is, it's a soup to nuts. If we could design a complete system out in our communities, what would it entail? From prevention services all the way through recovery services. So when they created it, the goal was to be able to use that, hopefully, to develop state and local planning for identifying gaps in the system, allocating resources, and making policy decisions. So what we did was we developed a survey, actually we did 3, that we sent out to the local Alcohol, Drug Addiction, and Mental Health Services Board, asking them about what they had in their local communities. And they're the entity that under Ohio statute is responsible for planning, monitoring, and evaluating the local behavioral health system. So we surveyed all of them, and they were terrific partners. And the report then includes information from them. And we were specifically asking, again, about service availability in the communities that they serve, prenatal all the way through the 25th year, and available for caregivers. So this continuum of care is an evolving framework. It includes 11 domains, and you'll see them listed on the right-hand side there in that box. Those are the domains that are in the continuum of care. And then each one of those domains, there's a bunch of services. We also thought it was really important at the state level, I'm sure level 2 was, we need to have a common vocabulary so that when I say prevention and you say prevention, we're saying the same things. So what we did was we actually laid out the entire continuum of care in the document and then provided a glossary or definitions for all of those services. Now some folks, as we move forward through this space, may say, that's not the definition we use. Great, then let's have a conversation about that. But you've got to start somewhere. We actually listed each domain, all of the services under that domain. We then listed the definition, and then you'll see over to the right on that upper chart right there, we provided the citation for the definition that we used. Again, we think it's important to have a common understanding and a common language about what we're talking about. And actually, we're seeing this work ongoing right now at the state level in regard to the state's efforts to look at developing a crisis continuum of care. They're right now going through part of lots of things that are going on, but putting definitions to the words we use. We've done that, and we've taken the first stab at it. Now we can let folks kind of come in and tweak with things. The other thing we did, and you'll see this in the lower chart, was again, we took those 11 domains, all of the services under the 11 domains, and said, okay, in the ideal world, which we want to create in Ohio, what services should be available for what age young Ohioans and caregivers? Now again, folks may disagree. We worked on this with a number of experts on this, but this is what we think in this report. These are when these services in local communities should be available to young Ohioans and their caregivers. So we outline those. We also in the report outline challenges to creating and accessing a continuum of care. We know there are challenges. I've heard about it already this morning. We heard about insurance coverage or lack of insurance coverage. I've heard workforce. I've heard a variety of different things in the conversations today. But the ones that we lifted up specifically were parity, funding, workforce, importantly for young Ohio, caregiver understanding and participation. It's not like the kids are driving in many cases, race, data, and others. And we discuss all of them. Chart will show you right here a great example to challenges to creating and accessing a continuum of care. Map of Ohio, obviously, with all 88 counties. What we highlight on this map is data from 2017, areas where there are practicing child and adolescent psychiatrists by county. And you can see that the lightest color down at the bottom there is there are none. Look at the state of Ohio. That's an enormous problem, not just in Ohio, but it's particularly challenging here. And when you look at the age of psychiatrists, last I looked, it was a number of years ago, the age of the average psychiatrist in the state of Ohio was somewhere in their mid-50s. Think about what that means in the aging of this state. So this plays a significant role. We know we have workforce challenges, but this is one of them. All right, Tracy mentioned that we went in and did county analysis, and she and her team did a specific breakout on the Appalachian counties, and I'm going to turn it over to her in just a couple minutes. But first, I'm going to highlight for you what is in our county profiles. So for each of our 88 counties, we did this profile. All right, we included state and county statistics. We included by age group the Medicaid profile. We also included behavioral health conditions among young Ohioans as defined by Medicaid. You'll see in the lower left, we highlight the local Adams board. Most of our Adams boards cover one county, but a good number of them actually cover multiple counties. So this one's an example. Adams, Lawrence, and Scioto, excuse me. So we highlight information from the local Adams board. We then also include behavioral health measures by age group. And then in each of these, in addition, we include that information us their local community. I want to take a moment to be appreciative of tips and these type of. For an Adams board to say in response to a question of, do you have unmet need in your community? For an Adams board to put down on paper, yes, we do. And we ask, okay, what is that unmet need? And they detail out what their unmet need is. I think that takes a little bit of bravery because they get money from local policymakers and others, and I think there's an expectation that they will meet all needs in their community. We all know the reality is the need exceeds what we have available. So we are enormously thankful to the Adams boards for where there's unmet need. It also, importantly, provides us with a roadmap. We now know in those communities where we can be looking to target resources and where we have holes in the continuum of care. So again, we've developed a common definition. We've said where the ages services should be available, and now we've lifted up where there is local need. We think we have an enormous opportunity that we need to seize upon right now to take this to the next step. And I'm going to turn it over to Tracy, who's going to talk to you about a special drill down now.
Thank you, Joan. So before we leave this for a moment, I just want to go through a couple of the items here that we were able to gather. So I don't want to sugarcoat in any way the challenges involved in gathering some of this data. It literally took probably about 8 months between the time that we requested data from the Department of Medicaid, had several meetings negotiating what kind of data was going to be used, et cetera, and then actually information out it was, but the is able to use with so many children across the states receiving insurance coverage, receiving that basic coverage through Medicaid. It's a wealth of information. So, I mean, looking at just the behavioral health conditions amongst young Ohioans as defined by Medicaid. So this is information that they actually have on like cost reimbursements, right? So we looked at, for example, ADHD, anxiety, adjustment disorder, other depression. These were all top diagnoses that we found across the state. And then when we looked at, for example, the Medicaid profiles, we asked them to break this out by age. We want to know how many of our young Ohioans 0 to 3 are covered or have a behavioral health condition, all the way through to the oldest profile, ages 19 to 26. And we chose that particular age range because we have so many youth who are in the child welfare system, who are emancipating, who are aging out, who are still covered by Medicaid. And we know that many of them, do require services. So we want to make sure that we're getting that information about, okay, so how many do we have covered? Along the lines of, let's see here. Okay, budget information. So this is more of descriptive information that we wanted to gather because we know that not all our ADAMS boards are the same. Some of them receive significant local resources, whereas others don't, which adds to the disparities then and what they're able to provide their communities. So we wanted to make sure to point that out and also, present that as part of the context of the story that we're trying to tell. All right, so for Appalachia County, what we were able to do weeks was take a look at the 32 counties that make up the Appalachia and do something similar. The number who are experiencing by age group, and then also by behavioral health condition or diagnoses. So as you can see here, I mean, for behavioral health conditions, we have a very low rate of diagnoses in the ages 0 to 3. But it steadily increases as our children get older. And there's a couple, and I'm sure there's others in the room who could more eloquently speak to that, to this particular issue, but there's a variety of reasons for why that might be. So when we talk about overlapping systems, as children are entering schools, or as they're having interactions with different systems within their community, whether it be juvenile justice systems, child welfare, or I mean just well child visits if they're playing athletics or anything else. There's an opportunity for a health professional to either identify something that isn't that they need to dig into a little bit more, make a referral, or do some of the hard work of diagnoses. And, as we're seeing, it really picks up in ages 4 to 9. And more than likely, those are children that are entering preschools, children that are enrolling in kindergarten. And, there's an opportunity for a teacher or school nurse or someone else to make that referral for them. And then in terms of behavioral health conditions that we're seeing in children, especially in the region, as covered by Medicaid, ADHD remains at the highest level, followed by anxiety, adjustment disorder, other depressive disorder. So it very much mirrors, I think, the trends that we're seeing throughout the state of Ohio. Now, it is my hope and my goal that we're able to get more regional types of information like this going forward, by the different regions in the state, because I think that it's important, number one, to recognize that there are certain regions of the state that have been underinvested in over time and also have significantly more in terms of gaps of services, whether it be because of behavioral health professionals or interventions that are available within the areas, or will continue and hopefully of our work. So another area of analysis that I asked some of my colleagues, Kim Eckert and Morgan Hyatt, who are just amazing, to do, was to take a look at some of our kids count data in the region. So Children's Defense Fund for about 30 years has been the Annie Casey Foundation's Kids Count organization in Ohio. So every year we produce county by county profiles of child well-being on a variety of measures. But I mean, typically they're around health, nutrition, families and communities, education, and economic well-being. And so because they're county by county, you know, it's, I don't want to say it's easy, but it's, you know, it's one of those things that we can aggregate that data into like an Appalachian profile. Now, there's always limitations like that. If you're interested in it, all 32 of the Appalachian counties here in the state. But one of the things that we looked at was, okay, if we were to regionalize this, or not even regionalize it, but just different types of communities within the state, we broke it out to Appalachian, metropolitan, rural, suburban, and then we have a state average and, you know, Ohio. And so as we were looking at things like children living in poverty, one of the things that jumped out is that the Appalachian region actually has as high, if not higher, a poverty level as our metropolitan regions in the state, obviously higher than the state average. In terms of unemployment, we saw something very similar. Again, children enrolled in Medicaid. You know, we saw rates just at and a little north of 60% of children. So in a way, you know, you don't necessarily want to see that because that's obviously an indication of high levels of poverty. But at the same time, you know, we are thankful that we have the safety net that children and families can depend on as a lifeline for their health. And then in terms of children in foster care, you know, our metropolitan regions are leading in that area, but again, not far behind is our Appalachian region. And no doubt, I mean, poverty, I think, in a lot of ways are the sources and the root of a lot of the challenges that we see in our communities, whether it be, you know, children in foster care, children, you know, experiencing consistent chronic health issues because they're not getting treated early. You know, I think that these things all stem from that particular, you know, that particular violence. So at this time, I'm gonna.
Yeah, we've just got a couple of slides left. Both stay up here, it might be
Sure.
easiest. So some of the key findings that we found were obviously Medicaid is a critical partner in driving policy changes. And we've talked this morning about Ohio Rise and what that's going to bring to all of us. Ohio Rise is a great example of that, so we're excited about that. We also heard from many of the Adams boards that they needed consistent and timely access to data. This ties back to our general theme, right? We need data to inform policy, and informed policy will hopefully develop the service system that we need and need in all of our communities. And finally, the Adams boards reported the availability of services for young Ohioans at each age and stage of development is inconsistent throughout the state. Again, this goes back to we need a robust continuum of care so that every young Ohioan can receive the services they need when and where they need them. Finally, and then one ARPA slide, we've got some recommendations. We need to ensure parity of insurance coverage for behavioral health services. We also need to make sure that there's adequate funding allocated for these services. We have an enormous workforce challenge out there, and we need to address that. If we may be able to build it, but if we staff it, it's not going to do us any good. So we have. We also need and participation there's racial system, and we need to provide comprehensive data. We need to do all of those things in order to develop and support a continuum of care. There you go.
So I know that a lot of what we presented, it's, you're probably sitting there going, there's so much work to be done. It's a big size. But I'm here to tell you that, there's a lot of hope too. And I think that there's a lot of opportunity to realize that hope that are within our grasp as a state and as a community. And I'm sure all of you are very familiar with the American Rescue Plan. And there are around $3 billion unallocated that we're waiting, and I hate to say waiting, we are actively working on in terms of trying to help policymakers make good decisions with how those dollars are going to be used. Not only for the right now of relief with the pandemic, but also how to make our communities more resilient, how to make them more prepared to meet and rise to the needs that we're seeing within our neighborhoods, within our families, and to be better prepared earlier. So a couple things that I'm offering up to all of you for consideration that we've offered up to many others is number one, state policy, adoption of a children's continuum of care for behavioral health. We need a framework that we can all agree on by which we can then measure where our gaps and where our strengths exist, and also to direct resources towards to buttress those areas where we're falling short on. Unless we can all get to the same point where we have a common and shared understanding, this is always going to be one of those things that are just within or just outside of our grasp because we're all thinking about it in a different way. This need for alignment of existing policies and practices is absolutely necessary. And the thing is, you don't have to necessarily start something new, like a whole new bureaucracy or a whole new work group and commission or committee to do this. We know that there are pieces of this being developed. And, in some cases, in coordination and with visibility of the other parts, moving parts of it. But there needs to be, I think, greater communication across the states on what this vision is that we're moving towards now. I mean, Joan and I kind of been working this day as there need to be great levels of communication, policies that are being practices, and going here, folks. The next part is local efforts and continued progress on the data front. So, there are many in the state who have been discussing, actively working towards, and being very successful around building pilots that can, address some of these challenges that we're seeing in terms of workforce, just that lack of human capital. And what we envision is to work with some of our counties and Adams boards to create more pilots, more coalitions of the willing, right, to create and build this robust system. And what that looks like, there are multiple ways in which that could look like to build a continuum of care for a county or a particular area, like an Adams board service area. But we would invite and we would also encourage policymakers to invest in those willing partners that raise their hand and say, yes, I want to do this. We want to spend the next 3 to 5 years doing the hard work, building out a complete continuum of care within our region, and seeing what it looks like for us. That from simulate. The next piece around data collection. So we would also encourage our policymakers to invest in robust data collection across the states. And this could be like funding a startup. Funding a startup of like-minded partners who can build systems that would actually get us the data that we need that all of you need in real time. And then, of course, additional tools for local communities and boards to assess needs. So we have, 52 Adams boards?
50.
Or 50 Adams boards. And when we did our surveys, one of the things that we found was there's a variety of ways that these boards are doing their data collection in terms of their needs assessment, which isn't necessarily a bad thing. But another thing that we heard was some of them saying, you know what, we need better tools. We need better tools to do this. And some of them even having their own proposals and giving us like journal articles on what that could look like. So why not, leverage that energy and those ideas and fund a pilot like that could help Adams boards do their jobs better and do their needs assessments and monitoring and reporting better. And the last piece is around the county pilot programs on building, sorry. But one of the things that we wanted to talk about here was around, just what if, right? What if you were to do that was large but captured like a region? And I know that there's several examples of that in the state. One of them right here in southeastern Ohio, that's federally funded. But that could provide career pathways. That could build out loan forgiveness programs. I believe around 40 years ago, the federal government stood up this huge loan forgiveness program because they had a shortage of teachers at schools for the deaf around the country. And they sent hundreds, thousands of teachers to be teachers at those schools. And well, as a result, a lot of they were able to build up this huge pipeline, but it wasn't consistent. They weren't doing it consistently year after year. And so about 10 years ago, what we saw was a large number of these teachers right here in Ohio at Ohio School for the Deaf getting ready to retire and no one really ready to take their place. So what we need to do is prime the pump around a human capital pipeline for behavioral health and continuously feed it. Don't fall into the situation where we have so much more need out there than we can possibly serve. We have literally beautiful buildings in downtown Columbus that are empty, that we can't fill, right, with behavioral health providers, which is a shame, especially when you have children waiting 6 and 12 months to get served. So that is all that I have to share with you right now. And our presentation in terms of our, reports, some of our recommendations, what we see as a hopeful way forward and a once-in-a-generation opportunity to do that. And, ready to take any questions. I believe we have about 20 minutes for questions.
I think it's like 5.
Oh, 5 minutes.
Oh,
sorry.
I don't know.
We have time for questions. So anything on continuum of care or by which we yes, sir.
So how many of this, so filling the gap in the continuum of care, I've been working in the anti-heroin world in Northern Kentucky for a long time. And what I've discovered is that people are doing what they want to do. And you need to bring in different people to fill in the continuum of care. The people who want to do the stuff that's in the middle. Who's organizing efforts like that to bring in new to the old folks? We do good at.
Can I answer that?
So I think that's one of the questions that, excuse me. So the question was, who is going to build this continuum of care and bring in new services where they don't currently exist, recognizing that services may currently exist in a local community, but they may not fill all of the gaps. And so I think my response would be, that's part of the question that we're raising, right? We're saying it needs to happen in the local communities. I think the state could step in at a leadership level and propel some of those conversations at the local level. But you also have in Ohio, and I've heard this talked about here locally today too, or during this conversation, it's a very locally driven state, right? And we do have 50 Adams boards. And I think Adams boards be propelled to support in fostering those conversations in their local communities as well. And it's one of the reasons why we like to partner with the boards on these surveys, because they are the leaders in their community. And now that we've asked that question of, do you have an unmet need in your community? And the response back has been, yes, we do have an unmet need, and we've defined what that unmet need is. We believe we've now kind of helped set the stage, not to pat ourselves on the back, but we've set the stage for, we've told you this should be, you've identified a need, now let's figure out in our local communities how to fill that need. And to Tracy's point, some communities have local levies, but not all communities have local levies. So figuring out then a collective statewide way to finance those services is going to be another big part of that conversation. And that's a state and local conversation. So I think there's lots of players involved in that. But you're right, that's the question we were putting on the silver platter.
We now have managed care organizations who are glad to pay for the service that their customers have, if only it existed within the geography. I really think it's a matter of bringing in business schools and saying, look, you know, here's the source of revenue, here's the population that needs it. We have actuarial data around how many people need it. Can you open up a 2-day-a-week pop-up, you know, counseling office and handle the 40 students that we have here in our area and cover the difference? We rely too much on Adams Force, and one of the problems is over the 25, 30 years that they've existed, they have in many places created entrenched, self-reinforcing, and self-congratulating systems with a lot of rhetoric around the jobs they do and not a lot of creativity around the jobs they don't.
I'll tell you.
You know, I think that what we'll see is all communities are different, and I really believe it takes all players coming to the table. And to your point, I mean, we have hospitals like Nationwide Children's Hospitals and Hopewell and others that are partnering communities and that are identifying those needs and try to fill in those gaps. So, I mean, I agree. I think we need, it's not just the Adams boards, it's not just, you know, certain public advisors. I think it's everyone at the table, you know, being creative about how do we address this? Because, I mean, I'll go back to what I said earlier. I mean, you either pay now or pay later. And I mean, we have, with so many children, so many young people having a mental or behavioral health diagnosis and having inconsistent care, that's going to mean significant negative issues in their lifetime, that of their families, of their community. So I agree, the stakes are too high for it to be any one system to handle this.
Yeah, and I would agree. I think that the other thing that we're seeing, Tracy raised the hospitals. I know in Northeast Ohio, where I physically live, we're seeing our hospital systems developing behavioral health hospitals. We're seeing that not only occurring in Northeast Ohio, but around other parts of the state. We're also seeing a number of providers come in from out of state with either for-profit models or nonprofit models. I think the behavioral health redesign that occurred most recently is going to prompt a lot of different things as well. So I think it is going to take everybody. That question of how do we get everybody talking about this and moving forward is what we hope to do, is to fan that flame that we have to talk about this and we have to figure out how to fill these gaps. How it's actually going to happen in each local community, I think, is going to look different because all of our communities look different. It's a conversation that we start and provide as many tools and as much of the kind of legwork done ahead of time as we possibly can. And that was our goal with this report. I wish we knew the answer to everything. We don't. But we think we've gotten our 88 counties in our state off to a great start with what's included here. And it's going to be a messy process, but it's an important one, like Tracy said.
Yeah, I want to say thank you to everyone that contributed to this. It's not something that's so clear can put out there that's so clear about the gaps. Again, I've worked in this region for a long time, and it feels like we've said it for a long time, but to see it in this way is really exciting. And I think, the part that stood out to me is this, Tracy, you mentioned that there's confusion around the definition of a continuum of care, although healthcare has been doing continuums of care forever. And so I sort of want to challenge that and say, no, we don't. And say that if we don't, parity is the only thing that gives us equity across the state. And you know that, we avoid the conversation over and over again. So I'm glad that I believe it's like first on your list of solutions, and I appreciate that, so thank you.
Yeah, I would say also that the Department of Insurance and some leaders at the state level have made commitments in this parity space, as have past administrations too. It's anybody that's dealt with with parity and insurance challenges. Can be quite complicated when looking at insurance coverage. That's no excuse though for not addressing it, and we need to help ensure that we have state got federal laws and we still don't have parity, and so I think that's an incredible opportunity we have to fix.
It is, and just as a behavioral health provider in the region, and to the gentleman's point in the back, I would love to be able to create more services where our organization in the community identifies the gaps. Parity is something that allows me to do that with our teams, and so I do understand it's really complicated, and I do understand that when things are complicated, we move on to the next section, and I appreciate what we can learn from them, but we've been doing them a long time. So I just...
No, I agree.
tried to be quiet.
I agree. It's sometimes, pilots are the easiest way to start opening the door for more things to come.
They absolutely
Yeah.
are, and I don't want to.
Yeah.
I don't want to discount that, and I don't mean that. I just had an opportunity to tell you.
Stop it.
Yeah, and our initial thought when so the question is about pilots and the validity and the long-term use of those. Our initial thought in regard to the pilots was to look at ARPA funding to say, look, let's go deep in for 5 years, take a serious chunk of change, right? Give it to a local community and say, for your local community, you figure out how to create a continuum of care in your community. For some, that may be workforce issues. For some, that may be birds and cattle. For others, it may be, who knows what it is. But for your community, you figure out how to build a continuum of care. Because our thought is, until we do that, until we go all in and put the money behind it and the energy and all the resources, there's going to be 1,000 reasons under the sun to not have a continuum of care in your local community. So let's knock down every single reason right off the bat and then use the learning from that to help build out the continuum around the state.
And so I'm grateful for that, and I think I do agree. Thank you for that.
Any other questions, comments, thoughts? Maybe ideas for the next report? I know, Joan's like, please no. No, stop. All right, well, thank you all so much, and I appreciate your questions.
Thank you.
Thank you.